like you both to comment on your views of the medical home in the context of OCM and private payers using medical home, but also let's throw another factor in, and that is risk-based contracting, where physicians are going to take downside risk. In New Jersey, we've started, and we've been doing this successfully now for 2 years, prospective bundles, where you get one check for the entirety of care, and right now there is no downside risk, but it's going to move to downside risk. And we know with MACRA, CMS wants to move to downside risk, not just oncology. So if you could address it in its totality, it seems that we're moving from the early stages, which is basically get an EMR, have a nurse in your office, have your office available, to this mid-range thing where you're doing extra things, which is kind of OCM, but ultimately is it your opinion that the game is to get to downside risk, and what do you think about that? So I'll start with you, Brenton.
So yeah, I think as you mentioned, through MACRA, there is certainly a trend to downside risk being at least shared by providers. And in terms of the medical home, there's key components that will be important to managing that risk. One is having kind of a quarterback who can coordinate the care and ensure that the best care is being delivered throughout the neighborhood as opposed to just the clinic. And then the second being really engaging the patient in that care, engaging their views into the type of care that they want, in creating, whether it's technology or human interaction, a place where once the patient moves beyond those four walls, they're still a part of that clinic. And so I think that's a really important piece from the medical home part. In terms of taking downside risk and sharing risk and contracting, there's a long way to go there in terms of the data. So payers have had claims data for tens and tens of years, and clinicians have had clinical data, for centuries. And those two have rarely come together in a cohesive manner. And so bundles that are going on today in oncology are very broad. So lung cancer would be a bundle, for example, but the claims data doesn't have small cell versus non-small cell, stage 1 versus stage 4. And so for practices to take on that risk, they need to be able to understand the cost of those particular patients, as well as how they're performing compared to other practices. And so CMS has been providing claims data to practices as part of the OCM so they can start doing this. A lot of the payer models we spoke of, whether it's Aetna or others, have a component where the quality measures and other measures are a way to provide clinical data to the payer, so they can incorporate stage now, they can incorporate non-small cell, small cell histology into those bundles. But we have a long way to go to bring those together and provide insights where a clinician can responsibly take on that risk.
Yeah, I couldn't agree with you more. In our bundles, we are way even past. First off, it is a marry of the clinical data, the laboratory data, genomic data, and the claims data. There's no other way to do it. You're absolutely right. And allows the application of precision medicine at scale to do that. And now let's get Dr. Sagar to weigh in.
I personally think that the care coordination component, the emphasis on care coordination, is what leads to the success of the medical home model. Having the patient at the center and focusing on the other key tenets around it, education of the patient, making sure there's a shared decision component, making sure they're heard and what is the best treatment option out there for what their options or what their opinion is. What do they want from that particular cancer treatment? Is it curative therapy or is it palliative therapy? Does the patient really understand what's going on with all of the challenges that they have to deal with this new diagnosis? So it is a very challenging time for the patient. But if they understand things a little bit better, and each patient comes to the journey at a different point in time and different level of understanding. So I think it's the medical team's responsibility to judge where the patient is, how much information do they want to know, and how much information are they able to handle. But I think education is a key component to the success for them. Once they understand what the treatment is, what side effects do they expect? If it's a known side effect, how do they manage it? Those are all key components in trying to drive the total cost of care. Once the patient understands, and if their symptoms are managed really well with early palliative care, do they still choose the same therapeutic options in their fourth line of therapy or fifth line of therapy when there's not a lot of evidence supporting those therapies? So what outcome are we looking for? And building off of a patient who understands what their outcomes are, what their treatment options are, is what is going to drive this.